Okay, great. Well, I want to welcome you here tonight. Sports medicine is something I'm really interested in, obviously by the good intro. And I'd just like to go quickly through a little bit of, before we start about talking about specific stuff, the sports medicine team is composed of many different players, and it's not specifically one, there's many pathways to sports medicine, so if you're interested in it, there's a way to get there through many different ways, and everybody's important, for all the way down from primary care to specialist. There's the athletic trainers on the field with the athletes, to the physical therapists in the therapy room, to coaches, psychologists, nutritionists. So there's really a place for everybody if you're interested, and there's a lot of options as far as how to get there, and they're all important part of the team. So the goals today I'd like to talk about is first to discuss a little bit about age in sports. We're going to go over some common types of injuries and just what injury is in general, some common injury treatments, and prevention of some sports injuries, which will apply to both young and old people. And at the end, we'll go over some real specific stuff, specific injuries that many of you may have already had. So the first thing we'll talk about is age in sports. And if we look at younger athletes, we know that the children are not the same as the adults, and that's something they hammer into us when we're training, that children are different. And one of the things that makes this very interesting is that even in different children of the same age, they vary widely as far as how big or how tall or how skillful. So the other thing too is not all sports are the same. One sport has specific injuries that you might expect versus others. And so that makes it very interesting for us to try and sort those out and come to a conclusion. The different age groups suffer different injuries. A younger pediatric patient may suffer a different type of sports injury than an older type of athlete. So you got to keep that in mind. And again, the size and the speed and the skill all vary tremendously, not only based on their age, but also the level that they're at. And just for an example, we'll look at this x-ray of a knee. On the left, you have the children's x-ray, and you can see the growth plates are here. These lines are where the bone is growing, where it's getting longer. And so you see on the adult x-ray that those are fused. As you become an adult, they fuse. And so this introduces a whole new area where you can get injury in the growth plate. And we'll talk about that a little bit later. But that just emphasizes the point that different athletes are different. As you get to be a little bit older and you're continuing to be active and participate in sports, you tend to develop more overuse types of things. Things like tendonitis, you may have heard that, or bursitis. Sprains and strains are also common in both age groups. And we'll talk about that a little later too, specifics. And so if we look at the common types of injuries, you say, what is injury? Well, there's two main groups if you look at it. One is an acute injury, such as a car crash or a fall where you have an acute trauma, strains, bruises, fractures, that sort of thing. And the second type is an overuse type of phenomenon where instead of one discrete injury, which is very severe, you have multiple small series of repetitive injuries over time that in time build up into one larger injury. So what can be injured? What can get hurt? Well, basically everything can get hurt. Things that are commonly injured, muscle, tendon, bone, ligament, joint, and my colleague will talk about nerve, including the brain, a little bit later. And so now you know what can get hurt, how does it get hurt? So if we look at there's different types of injuries. There's abrasions and lacerations, or injuries to the skin. Abrasions more like a scratch, which can be superficial, it can be fairly extensive. Lacerations are cuts, such as with a knife or some sharp object. Sprains and strains are injury to ligaments and injury to tendons and muscle. Contusion is a bruise. So if you see in this picture, there's bruising, there's contusion to the soft tissue. So that's what contusion is, basically a bruise. Tears can occur in ligaments, they can occur in tendons, capsule, all kinds of soft tissue can get torn. Dislocation refers to a joint, so the different joints in your body are held together by strong ligaments and bony architecture, and those can go out of socket. And we'll talk about shoulder a little bit later. That's the most common dislocation. but when the joint is out of joint, it's dislocated. And then fracture, bones are very strong, but when the energy is exceeded, they fracture. So we know what can get injured and how it gets injured in a general sense. So what do we do to treat it? And if we look at common injury treatments, and a lot of these fall under easy, simple things first. The RICE protocol, or the RICE treatment, is very common across the board for most injury. And so we look at R stands for relative rest. And so what this really means is you're just going to rest from the inciting event. You're not going to keep injuring yourself or keep hurting yourself. You want to let your body heal itself. Ice is a very good tool. It's inexpensive, and it's very good at modulating pain, and it helps with swelling, reduce swelling. And typically, I'll tell you that you want to ice for about 15 or 20 minutes at a time, and then let your skin rest for about 45 minutes. You don't want to put the ice pack on for 3 or 4 hours. I can tell you I've seen a couple frostbite and skin burns and things like that you want to try and avoid that. So you want to give your skin time to rest. So 20 minutes at the most, and then you can follow that up with a few minutes of rest of the skin. And you can repeat it if you'd like. Usually wrap it in a towel too. You don't want to put the ice right on the skin. Compression refers to things like ACE bandage or braces, where you can wrap the extremity. What that does is helps reduce inflammation. It also typically reduces the motion of the joint, which also helps you rest. Elevation is a good tool to reduce inflammation. You really say above your heart, but any elevation can reduce the swelling. It also reduces pain and helps you feel better. After you've done that, that's usually the first set of things you want to do. After that, then there's some other specific treatments you can employ to try and feel better. The rehabilitation, and that can be a whole host of different types of treatments, including physical therapy, home therapy, water therapy, and that sort of thing, under the direction of either therapist or massage or other specialists, part of the team that helps get you better. Anti-inflammatories refers to medicines, both prescription and over-the-counter, such as Advil, Aleve, and there's some Celebrex prescription style. And what those do is reduce inflammation. Unfortunately, they're not without side effects, the anti-inflammatories, and so they need to be used on a judicious basis and not too much, because they can cause some trouble if you take too much. A brace goes along with the compression. It helps limit the joint. It also protects it. And there's certain types of braces, such as after ACL surgery or after a shoulder dislocation, that you can use to try and minimize your recurrence and also help you get back playing your sport. And then surgery. There's certain injuries that generally do better with surgery, and sometimes surgery is required when all else fails and all these other things fail. So in general, those are the injury treatments, and we'll go over those as we go through the specific injuries. You'll see that we kind of rehash those treatments. So briefly, I'd like to touch on some prevention, because obviously if you can prevent it, it's much better than getting injured. So what helps you prevent it? Well, the first thing is you always want to warm up and cool down. Very important part of being active. Stretching can help your body ready you got to get the blood flowing. You got to get your body ready to exercise. And if you get going at 100% from when you're real cold, that puts you at higher risk of injury. And same thing when you're finished. You want to cool down. You want to let your body kind of finish off its exercise, because exercise is really important. You want to stay active. Whether you're young, you're old, or in between, you want to be active. Cross-training refers to different types of activities. So it's better to try and do different types of sports during the day. One day you go and you do some jogging, and the other day you do some stationary bike or some biking, mountain biking, whatever you prefer. It's just to mix up the forces your body is seeing, and it's going to minimize your risk of getting an overuse injury or some sort of injury. So every day do a different type of activity, and you can mix it up. It's also a little more fun sometimes. You want to hydrate, you want to stay hydrated, especially as summer's coming. We want to get everybody out there participating. We want to make sure you don't get dehydrated. So some other general things about preventing injury. You want to try and play by the rules. The rules are there generally to have fun and also to prevent injury. You know, they changed the rules on how you can tackle in football, and that reduces cervical spine injuries very significantly. So you always want to play by the rules. Certain sports have protective gear, and there's a reason for that. You want to try and use that as much as you can, and you also need to know how to use it. If you don't know how to use it, it's not as effective as it would be otherwise. Typically, you don't want to play through the pain. Your body's telling you something. Your body hurts. There's a reason. And having fun will help you try and prevent injury as well. I just want to touch briefly on this picture. Can anybody tell me what the most important safety prevention item in this picture is? The helmet, exactly. Very, very important across the board, age group, and my colleague will obviously talk about brain injury, but it's very common for children to wear it, but it's less common for adults, and I'd really encourage you to wear a helmet anytime you're riding a bike. It can really reduce your injury significantly. So if we talk about children just briefly too, obviously you want to be well supervised and coached for the most part. Again, they want to wear proper gear. You want to have that well-fitting. Again, they vary in their size and their how old they are. You know, the same age, maybe vastly different sizes. So we need to make sure we have the right size for that athlete. And you got to play on safe surfaces, places that were designed for certain activities. And then as far as overuse goes with your children, it's usually generally a good idea to limit how many teams they're playing on. I have a lot of patients that come in and play on 2 or 3 different baseball teams and throwing a lot, and that really does put you at higher risk to having an injury. Trying to limit how many teams, usually 1 or at the most 2 is probably the most you want to do. And here in Southern California, the weather's good most of the year, so everybody plays year-round for the most part. In other parts of the country, they have to take a break because it's snowing outside. But you need to take regular breaks, because if you play the same sport all year round, do the same activity all year round, then that's going to put you at higher risk. And so taking a break, playing a different sport, is going to help reduce your risk. It also helps with skill development and prevention of injury. That's not always easy, though. So now that we talked about some general stuff, we're going to get into some specifics about different injuries. And probably one of the most common injuries we see is an ankle sprain. And so by definition, the sprain is an injury to the ligaments. And you can see here, the foot is here, the shin bone is here, and these ankle ligaments are holding the ankle together, held by strong ligaments. And when you roll your ankle in, which is most common, you get injury to the ligaments. And there's a spectrum of injury from a little tear to a full tear. And that's what the ankle sprain is. Obviously, you roll it in and it hurts right away, and then it swells up, and you can get bruising. You can even feel a pop sometimes if it's a very severe sprain. So the treatment, like we talked about, you want to do the RICE treatment. You want to rest. You want to keep it iced. You want to elevate. Put an ankle brace or ACE bandage. That's a good treatment to compress it, reduce it. And then after that's settled down a little bit, you want to get into some rehab. And what we're trying to do is you're trying to re-educate the muscles and to dynamically stabilize the ankle. You got to get those back in tune. And the brace helps support it a little bit while you're getting better. And then hopefully after that's all said and done, you get back to your sport. And you don't really need a brace typically, although some sports have a higher rate of ankle injury. Some people wear braces prophylactically. So if you have a bad enough injury, most enough injury to get, instead of a sprain, you get a fracture. And fracture is a break in the bone. And a real common question I get in the office is it a break or a crack or a fracture? And so in general, they're all synonymous. And so there's obviously this is broken. I don't think there's any question here. But if it's, you'll hear the term hairline crack or break. And really, a fracture, a break, and a crack all mean that the bone is compromised. The structural stability of the bone is injured. And in children, you can actually get a bend in the bone rather than a crack. And that's a specific type of injury. But as you get to be older and in adults, you get a fracture. And they're all basically the same. The real question you ask is it displaced or is it non-displaced? And so a non-displaced fracture is a crack in the bone, but it looks normal. It's just fractured or broken. And a displaced fracture is something like this, which is not, it looks crooked. So how do we treat fractures, or what's the treatment? Well, that depends on the fracture, it depends on the bone, and it depends on the age of the patient. And there's a whole host of treatments. From a cast, typically non-displaced fractures or fractures that aren't moved at all can be treated without surgery or treated in a cast or a splint. Manipulation is when you pull on it or push on it or try and realign it a little bit better. So if we go back to this x-ray, obviously it's a little crooked, so we want to try and straighten that out. And this is a child we can see has open growth plates. And so children do well with manipulation and in cast for the most part. And so we want to try and get it a little bit straighter. You can do that by pulling on it, and then you put it in a cast. And that can stay or that can't stay. Typically in an adult with forearm, that needs to be surgically fixed because it needs to be well aligned. And so surgery is reserved for, there's specific fractures that do well with surgery, and there's others that don't need surgery, and so it's really individualized. It depends on the injury and the displacement of the fracture and which bone it is. But those are in general the treatment of a fracture, trying to realign the bone in proper alignment, and then you're trying to get the bone to heal. Bones are good about healing, we just got to get them lined up while they're doing it. And then after that, get back to sports. So if we look at a specific injury in a child, this is a growth plate fracture. So as we saw in those x-rays before, the growth plate is here. This is a wrist, that other was a knee, and this is an ankle. Foot's down here and the shin bone is here. This is the growth plate. It's where the bone is growing, and you can get a fracture across that growth plate. Here you can see the growth plate right here on the ankle, and the fracture obviously comes right across it. Now, this is a non-displaced fracture like we talked about, so that's good. But if we look at a wrist, this is a normal wrist on this side here. Here's the growth plate right here. And obviously this is a little abnormal. The fracture has come through the growth plate and it's slipped off the back here, so we need to push that back over there like that and get that more aligned like that. So the growth plate fracture occurs in a young patient, in a skeletally immature patient, and so they have an ability to correct deformity, and they have an ability to heal very rapidly. And so for the most part, closed treatment with cast or splint is preferred. Sometimes if it's out of alignment, you got to manipulate it. And then there's certain fractures, again, that require surgery, even in a child. But these fractures typically heal well, and they heal rapidly. The problem is that there's growth plate, and the growth plate is where the bone is growing. There is some risk with growth disturbance or growth arrest. The bone stops growing in that area. And if one part of the bone stops growing and the rest keeps growing, obviously you can get a deformity. And so that becomes kind of complicated sometimes. But for the most part, the majority of the fractures that we see in children don't go on to have that, so that's good news. The next thing is a very common type of injury we see in the office is a meniscus tear. So I'll go over quickly this model here. The kneecap is in front. We're looking straight onto the knee. Femur is the thigh bone here. Shin bone is here. There's two C-shaped structures in here that cushion the bone between the femur and the shin bone or the tibia. There's one here. There's one here. And what that does is that cushions the bone. It's like a shock absorber. Ligaments here stabilize the knee, and we'll talk about ACL a little later. As the knee moves through the range of motion, these cushions, they cushion and they allow gliding of the joint. And those can be injured commonly by a twisting injury. Also in contact sports, football, somebody crashes into your knee, you get tears of that. Or if you're cutting, you're pivoting, you're making quick movements, you can damage the cartilage. They also are very highly associated with a ligament injury, so something like an anterior ACL or anterior cruciate ligament injury, which we'll touch on briefly later, can damage the cartilage, because as the knee twists and the ligament ruptures, it can tear the meniscus as well. So what do you feel when you have a meniscus tear? Well, it typically hurts, and some people describe it giving way, or they feel their knee is loose. And obviously if you have a ligament injury also, that can make your knee feel loose, but just an isolated meniscus can also do that. People describe a locking sensation if the mechanically blocks your joint. If we look on if a piece is broken and it's flipped over here and it's actually like a monkey wrench in the joint, it's physically blocking. You can get a locking sort of sensation. Clicking, popping, although knees typically make popping and clicking in general, they feel worse. And then typically when you have a knee injury inside the joint, you get swelling in the joint. So this is an arthroscopic picture of a meniscus. It's the medial meniscus. The femur is here, the tibia is here, and that's a normal meniscus. You can see it's nice and smooth. There's no problem. This is not normal. Again, it's almost essentially the same look, but here there's the meniscus is actually torn back here, and it's the piece is flipped in here, and you can imagine that if that piece is flipping in and out of that area, first it's going to hurt. It's like a rock in your shoe when you walk, but also it can block the knee. It can give you popping or clicking. So what do we do about a meniscus? Most of the time these come to surgery and either trim out the tear. Unfortunately, this tear is not one that you can repair. The blood supply to this part of the meniscus is very poor, and so there's no healing potential of the tissue. So even if you could put it back and hold it somehow, it won't heal. So what they call meniscectomy, or removal of part of it, you come in and you snip out the damaged part. The healthy part, the part of the meniscus that's not damaged, we leave that. And the good news about the arthroscope, this is arthroscopic picture with the camera. You can do it through a minimally invasive surgery through tiny incisions and faster recovery. And also you can see very well, so you don't have to take out any healthy tissue if that's not necessary. So if we move on now to shoulder dislocation, we talked about a joint coming out of joint. So the most common joint to dislocate is the shoulder, and the reason for that is it's the most mobile joint in your body by design. It's a ball and a socket joint. Here's your shoulder blade here, collarbone is here, and then the shoulder is a ball and a socket. And it really is more like a saucer than a socket. There's not that much bony stability. The arm bone is here, and that's the humerus. So the shoulder has the best range of motion of any joint in your body, and so that also unfortunately makes it the most unstable. It still takes a little bit of force to get it out of joint, but it does happen pretty commonly in sports, contact sports, hockey and football. It's pretty common, basketball. There's a whole subset of shoulder dislocations which are not really traumatic. They're because the body is loose, the ligaments, the tissues they're just built loose. And so those people have problems with unstable shoulders. That's a whole another lecture for a different time. But that's generally separate from a traumatic dislocation, which is what we're going to talk about, where there's a force that knocks the shoulder out of joint. If you look at this x-ray, this is a normal looking x-ray. It's one from before. And you can see the ball is well centered right in the center of the socket. Here's the socket here, and the ball is in front. So that's an anterior dislocation, which is the most common. So what happens when this happens is you get deformity. It looks a little bit abnormal when you look at the player or the patient. And what do you do about it? Generally, closed manipulation is the treatment. And if you get to it right away, you can sometimes do it on the field or on the court. Once the muscles start to spasm, though, a lot of these need to go have some sort of sedation in the emergency room to get them back in. This is the maneuver. One of the maneuvers, there's many that have been described, but this is one of the most common, where somebody pulls that way, somebody else pulls that way, and pops it right back in. So what do we do about it after? So afterwards, we put you in a sling, and then we need to rehab it, because when you dislocate, you tear some of the tissues in there, and everything gets bruised, it gets swollen, and there's bleeding in the joint, so we need to rehab it, get you into therapy. And then some people have recurrent instability, and generally the younger you are when you dislocate the first time, the higher rate you have, a higher rate of recurrence when you to recur. So now we talked about the meniscus earlier. ACL is very similar, and that can come both contact and also non-contact, which is actually very common, where you're going to make a plant or you make a cut when you're making a move in soccer or basketball, and your knee gives out on you and it tears a ligament. You can also get injured when you're playing football. If somebody takes your knees out and tears your ligament. Coming down from landing is real common, such as basketball, volleyball. We see that quite often, where you land a little bit awkwardly and the knee shifts on you. And also the same thing with making an abrupt stop. So here's another schematic. We see the femur here. This is a side view as opposed to the front view we saw last time. Here's the tibia. And the ligament connects the femur here to the tibia and prevents this bone from moving forward on this bone. And one of the ways you get it is with hyperextension. And you can see this bone moves too far forward and you tear the ligament. That's just one of the mechanisms. There's lots of different mechanisms for ACL injury. That's a common one. What do we do about ACL? Unfortunately, ACL is pretty much a surgical injury because you can have partial tears of the ligament, but that's less common than a full tear. Partial tears sometimes can be treated non-surgically. But a full tear in somebody who wants to go play sports or cut, make pivots, twist, that needs to be repaired surgically, or else the knee will just continue to be unstable. They say 4% return without surgery, but it's probably lower than that, to be honest. But everybody's a little bit different. So now we talked about a little bit of acute injury. The last thing I want to touch on briefly is overuse. Like we said, a series of small repetitive injuries, things like bursitis, tendonitis. A bursa is a bag of water that lubricates a moving part. So every joint in your body has different bursa. They're lubricators. They let things move past one another. And if those get irritated, there's certain bursa in your body that give you trouble. There's some that never give you trouble. There's some that give you trouble all the time. So an inflammation in that bursa is a bursitis. And it's typically, the more you do on it, the more it hurts, and the less you do, the less it hurts. Same with tendonitis. It's overuse. It's a repetitive small amount of injury. Over time, you get inflammation of the tendon, and that causes pain. We talk about stress fracture. What that represents is similar type of injury to a bone. Bone is able to heal itself. It's able to repair itself. But if you continue to load that bone with stress over and over again without giving it time to rest, what can happen is you can develop a micro crack in the bone, and that can propagate. And we'll talk about that in a second. Common treatments, again, we said before, rest, anti-inflammatories, rice treatment, very similar to what we've talked about. If we talk about very common things we see is tennis elbow and golfer's elbow, and the majority of people with tennis elbow don't play tennis. And most people with golfer's elbow don't play golf, but that's the name that's been given, and that's the name that most people know it by. So what that is typically it's around the elbow, and if it's on the inside, it's a golfer's elbow, and on the outside is a tennis elbow, and it's pain with gripping and strength activities. And you get inflammation of the insertion of the tendon on the elbow. So how do we treat that? Not surprisingly, we start with the rice treatment, which is usually very effective for the most part. A brace, you may have seen people around town wearing an arm brace. It protects it, prevents motion. People that can't get better with that, they try cortisone and even surgery is occasional. How do we prevent? Again, we want to warm up. You want to get your body ready to play. You want to stretch. You want to use the right equipment. And the one thing you also want to use proper technique. And so sometimes people have recurrent tendinitises, bursitis from playing their sport that they like. So it might not hurt to take a lesson with a professional and make sure your technique is correct, because if you have a little bit of incorrect technique, that can put you at higher risk for developing an injury. And finally, stress fracture. Too much stress on the bone can fracture it, if that's a car crash or a fall from height, then obviously that's all at one time. If it's over time, you develop a little crack, and that can propagate. Often we see these in endurance athletes. It's classically described in military recruits where they're running a lot. People that aren't conditioned are at a higher risk. And the treatment, fortunately, is rest from what's aggravating it, or you can cross-train a little bit. You can do a stationary bike, and once you're feeling better, to try and offload some of that energy, some of that repetitiveness to try and stay active and stay fit, but also recover from your injury. So that brings me to the end of the first part.
Hello, everybody. So I'm going to follow that great lecture by Dr. Geller with concussions. And, you know, concussions are fairly common. Can everybody hear me, by the way? Is it be louder? No? A little louder? How about come a little closer to this? I'm a little tall, so I need, there we go. Okay. So let's see, this goes forward like that. Okay. So yeah, I'm going to touch base on concussions and management of concussions. You know, when is the player or the patient ready to go back to whatever they were doing that caused that concussion? So a lot of different things that, you know, I'm going to touch base on symptoms of concussion management and different guidelines. There's a lot of them by different organizations, and we'll get started so we can finish in time. So thank you, Dr. Larson, for the introduction. I'll skip this part and I'll get to the objectives. Like I mentioned, definition of concussion, a little epidemiology, and some symptoms, management, acute and long-term management, and different goals of how to manage the concussive and the post-concussive patient. So what's the definition of a concussion? There's different organizations, as you see. You know, I'm a neurologist, and the American Academy of Neurology is who I like to quote, just like, you know, the American Academy of Orthopedics is, you know, every field has their academy, basically, that comes up with guidelines and stuff. And, you know, if you try to read everything that's out there, all you do is read, basically, and don't have time for anything else. So you try to concentrate on your own. And my academy, that's the definition for concussion, basically. What it says is trauma-induced alteration in mental status, you know, that may or may not involve loss of consciousness. What people, you know, don't realize is that most concussions don't have associated loss of consciousness. They really don't. The patient could be a little dazed, a little confused, but they don't pass out completely. And there's also pediatrics literature. There is, you know, different types of literature, that type of mild traumatic brain injury caused by impact or jolt to the head. Concussions are actually a form of traumatic brain injury. You know, it doesn't have to be massive traumatic brain injury where a person's in a coma for like a month or whatever, but it's a form of traumatic brain injury because what happens is the sheer whiplash of any kind of momentum, your brain moving inside the skull, it's a closed space. It doesn't have much place to move. It's going to bang around. The inertia is going to help it bang around in the skull, hit, and that's going to kill neurons. Luckily, you have billions of neurons. You know, if you had only 100, 200,000, if you killed half of them, you'd probably be in a coma. So luckily, you have billions of neurons. The older you get, yes, you lose neurons. Neurons die, they don't regenerate. But nonetheless, you still have enough to maintain normal brain functions. But however, you know, during a concussion, when some of these neurons die, they swell. They result in all the symptoms that I will touch upon a little later, that result of that. So a little epidemiology, it's more common in males. Why? I don't know. Do males play more contact type sports? Yes. I mean, you know, we don't have a female NFL, really. You know, I mean, it's mostly a male, not that females can't play the football. It's mostly just a male-dominated sport. And, you know, a lot of the impact that they take, you know, it doesn't even have to hit your head. Just the jolt, the whiplash can lead to a concussion. Greater than 300,000 sports-related mild to moderate TBIs or concussions. You know, high school football alone, you see some epidemiology here. 20% of players are 250,000 concussions a year. So it's a decent number to have proper literature on and proper education to the public to understand what a concussion really is. You know, other risky sports, equestrian, boxing, ice hockey, wrestling, gymnastics, whatever that possibly, you know, you could fall, hit your head, or somebody could tackle you, hit you, cause whiplash, cause some kind of injury. Even driving a car. You know, you're sitting, somebody just slams into you in the back, your body whiplashes, people develop concussions. It doesn't have to be that their head hit the steering wheel or their head hit anything. A lot of people show up. I've seen a lot of people after accidents have concussions and post-concussion syndrome. So here's some, you know, sports and rates of concussions per 1,000 athlete exposures. Hockey's up there, you know. I don't know, is that because they still let people fight in hockey before they actually stop it, you know, 5 minutes into it, you know. But that's up there, and the rest of these are also very much contact sports. You get all the way down to to women's softball, you still have a decent number where you can develop concussions in that type of sport. Observed symptoms. So this is fairly common. This is an important slide. Vacant stare. The patient's awake, but they're not acknowledging you. You're talking to them. They're not really answering questions. They're not passed out, but they just don't seem to see that you're there. Not really aware. Confusion, inability to focus. Most common things. People become amnestic or they forget everything that happened right up to the concussion. They just, because what happens with that is that concussion, that whiplash, those memories that are going to be stored somewhere else in the brain when you develop certain memories the last couple days, the brain takes time through very complicated procedures or mechanisms to put that into long-term memory. They're not going to forget who their mother is or what their name is. That's a memory that you have for many, many years. They're going to forget things that happened like in the last week. It could come back, and most of the time it does come back, depending on the severity of the concussion. Disorientation, again, patients confused, have no idea where they are. They don't know what game they were playing for a second, they're out of it. Slurred, the speech doesn't sound right. You ask them a question, you get a completely different answer. It has nothing to do with the question you just asked them. Gross observable incoordination, they're just fumbling, they have no idea. They try to ask them to follow some command, and they just can't. Not because they don't want to, that's because that's their brains at the moment in a traumatized and going through this process of concussion. They become irritable. You can see personality changes. You could see somebody who's the most kindest, nicest person in the world after concussion having easily snap at nothing. Sometimes they just become emotional, cry out of nowhere for no apparent reason. Not that anything bad happened. They're just extremely emotional. Memory deficits, very big. People complain short-term memory deficits and trouble concentrating. They're like, look, I work and now I'm having issues just multitasking. I used to do things very fast and now I'm like slow. I've just slowed down completely. So that's another big thing to remember. And any period of loss of consciousness. Now, like I said, most concussions, they don't have loss of consciousness. But if they do, then that is technically called a grade 3 or a complex concussion, where there was a period, doesn't matter if it's a minute, a second, 5 minutes that the patient's out. If it's 5 minutes, a little trouble, you need to get to the ER as soon as possible. But any kind of loss of consciousness, basically, also part of the whole symptom list. Early symptoms, minutes to hours, headaches. Headaches are big. Headaches can last. I get a lot of concussive patients who come, look, I didn't have headaches ever in my life. Now I have headaches. Every day I have headaches. They don't sound like a primary headache disorder, meaning they're not like migraines or tension headaches that people develop when they're younger just because it's a primary brain mechanism chemistry problem. This is a traumatic headache, and traumatic headaches sometimes become extremely hard to treat. They don't respond to the same medications that we used to treat primary like migraine or tension and all this other stuff. Dizziness or vertigo, a little different. Vertigo means the world's spinning. Dizziness is you're lightheaded, but nothing's spinning. People sometimes call vertigo dizziness, lightheadedness, vertigo, whatever, but you could tease it out. Lack of awareness of surroundings. Like I said, they were playing a game in, I don't know, CV high school, and then they get hit, they have no idea where they are that moment in time or what's happening. Nausea or vomiting. Initially, because of the initial swelling of the trauma of the brain, people could develop nausea or vomiting. Now, if that persists, then that could be troubling, that there might be some kind of a intracranial or inside the skull, inside the brain, some kind of damage that's causing persistent nausea or vomiting. They could have been hit hard enough that they bled in the brain, and that blood is irritating certain parts of the brain, causing nausea and vomiting and all that stuff, and that needs urgent care and rush to the hospital. But I'll get into that later. Late symptoms, days to weeks. Now, patient has gone through the first 2-3 days, first week, whatever, and then they're still having symptoms. And this is kind of touching a little bit on post-concussion syndrome, pretty common. Post-concussion syndrome can last. Some people last for a year. Not that common, but it can, even over a year. These are some of the symptoms. You have the headache, sometimes can last. Yeah, it gets better, it gets less frequent, but it's still there. And mind you, these are people who've never suffered a headache in their life. Yeah, they've had 1 or 2 here and there headache where they didn't eat for like the whole day and they developed a headache, but this is different. They're having headaches out of nowhere. It's not because they didn't eat. It's not because they didn't sleep. It's because they're just having headaches now. Lightheadedness or vertigo, sleep disturbance. Patients describe insomnia. You know, I was sleeping fine 7-8 hours a day. Now I just can't sleep, can't fall asleep, can't stay asleep. So that definitely also gets disturbed. They get tired fast. You know, bright lights, noises and stuff get to them really quickly, whereas before they can't go out in the sun as much anymore because that in itself can cause a headache. They become sensitive. They're irritable, their personality changes. Some people say, who are you? They don't recognize some people because that's not who they were before in their personality, you know, close people to them. Anxiety, they get depressed sometimes because obviously these symptoms could affect your life. Imagine having this slew of bunch of symptoms where you didn't before and going back to your daily life. Do what you had to do, add this on top of it and, you know, try to manage or try to get by with all this. So. Poor attention, concentration, trouble concentrating. Well, if I had all this other stuff too, I'll probably have trouble concentrating too. So, and memory dysfunction, mainly short-term memory, having trouble maintaining certain new memories, you know. Second impact syndrome, you know, someone who has a concussion is 4 to 6 times higher chance of having another one, and it doesn't have to be a very big impact for the second one. It could be like a light impact that you never think could have caused a concussion, but if they've had one, the brain is more vulnerable to a second one from a much less and much lighter impact. So something to keep in mind. It's actually called second impact syndrome. There's a term for it. You know, there were some case series in the past with football players. You know, football, as the NFL has become huge on concussion because all these players who get hit develop years down the line, all these, you know, episodes of dementia, some brain injury and stuff. So the NFL has taken on complete new regulations on when a player can play again, when a player has to sit out, and what needs to happen before a player is allowed to play football again or any specific contact sport. But mainly football because, you know, I'm sure we all watch football. Football's a very contact sport basically, and constant, and you're not playing with 67-year-old, 70-pound other people. You're playing with big guys that if they hit you, you know, I'm sure it hurts and easy to get a concussion. So, you know, there's actually been episodes, I mean, this is a little old, 73, but a lot of deaths after second impact syndrome too. What happens is the brain is very vulnerable to that second concussion. It gets hit, it swells a lot more than it did the first time. Swells so much that, mind you, like I said, the brain's in the skull. It doesn't have anywhere to move. The human body's smart. You know, when it developed, it put one of the vital organs inside the skull, which is extremely hard to protect. I would say, not because I'm a neurologist, you know, but the most vital organ in the body is the brain. Without the brain, really, the other organs are just the other organs, basically, you know. So that's why the skull protects the brain. But mind you, when the brain moves inside, when it starts to swell, unfortunately, there's a few holes that the pressure could get released out of. And one of them is just, it's called herniation. What happens is if a pressure builds too much and there's no hole that's made purposefully by a neurosurgeon or somebody to relieve that pressure is going to push the brain out to the bottom. And unfortunately, a lot of your respiratory center that maintains your breathing, you don't think about breathing, you just breathe. But your brain is doing that. It just compresses and presses on that respiratory and you stop breathing and you die. So that's something that doesn't happen that commonly, but can happen, and it has happened. Second impact syndrome, again, you know, what's the pathophysiology? The autoregulation of the brain gets disturbed. You know, the brain has a certain way you get congestion. The brain has a great way of sending blood to places it needs to be, taking certain toxins away, making sure other toxins from the body don't get into your brain. It's a very tight barrier. It needs to be. Otherwise, if you could access the brain that easily, the brain could get infected, the brain could get hurt much, much easier. So what happens is, you know, that regulatory system from that impact, from that concussion, even that second one, it gets disturbed. So when it's disturbed, it can't do its job. When it can't do its job, it ends up in, you could have swelling, you could have increase your pressure, and it could result in a lot of these symptoms, basically, that I described earlier on the previous slides. This is big. Post-concussive syndrome. I see a lot of this. I get a lot of motor vehicle accident patients that I see. Their accident was a month ago, 2 months ago, whatever, and they have a lot of what you see, these symptoms on there. The cardinal features, the main features really are headaches. They have headaches. And like I said, these people never had headaches before, but now they have headaches. Daily, 4 times a week, pretty frequent. Memory deficits, trouble concentrating. So those are the main ones. You could see a lot of these other ones that are listed here. You know, they're irritable, personality changes, insomnia. Dizziness is pretty fairly common too. Not as common as headache, trouble concentrating, memory problems, but absolutely there. They complain about it. And what is this from? It's that concussion, that whiplash. Most accidents happens one. You know, I mean, a lot of people are just sitting, and most of them are just rear impact. You know, you're not expecting a hit. If you were, people can brace for it, I guess. You know, if you're not, then somebody just comes, you know, hits you, and you know, your body whiplashes. Whichever way it's going to whiplash. Your head doesn't have to hit anything. Doesn't have to hit the steering wheel, the rest, the headrest, whatever. But the sheer whiplash causes that whole disruption in autoregulation, that movement that leads to a lot of these symptoms, because those neurons that swell, they're dying or they're dead, and the swelling is their aftermath. And that in itself is leading to all these symptoms. Now the brain recovers. That's how you see all these symptoms. About 80% of post-concussive patients just clear up by like 4 or 5 months. You know, everything goes away, they're back to normal. Depending on the severity of the trauma, some symptoms I've seen last over a year, some to 2 years. Not as common. I would say about 15% will go. 10 to 15 will last over a year. And then, you know, you could have cumulative neuropsychological impairments. There's something about 20 adults in that age group, 16 to 26, after a second concussion versus matched controls, which were first concussion. So they took first versus second concussion, and look what happened in the second concussion patients: decrease in the rate of information processing, longer recovery time, deficits with increased severity and duration of mental status abnormalities, and with each concussion, things just get worse and worse and worse. So that's why a lot of these guidelines that have come out, you know, if you've suffered a couple concussions and you have persistent symptoms, I'll get to the guidelines. They really say that, you know, you should probably think about giving whatever sport or whatever it is that you were doing a rest, basically, for your brain's sake anyway. So, you know, this is another, I mean, you know, like for instance, the rest of that is just, you know, repeated trauma. Boxers, you're getting hit in the face for like 10 years, never good. But, you know, you're protected still, I mean, you know, glove, but you still get hit repetitively. And like Muhammad Ali, he has a type of Parkinson's, but that's still a traumatic brain, a constant traumatic brain injury. You know, I know he has Parkinsonian type symptoms, but you know, he also has dementia and all this other stuff and slowing processing of the brain, and that's because of just cumulative impacts. Now, why is it that not all boxers have it? If you really, I mean, Muhammad Ali is a big figure, you know, like everybody knows who Muhammad Ali is. If you really sit and talk to a lot of boxers, there's subtle, mild forms of dementia when they're done with their career. They may not be as advanced as Muhammad Ali, but it's there. So this is an important question. I'm sure a lot of people here, you know, might want to know, when can I go back after a concussion to do whatever it is that I was doing that, you know, caused my concussion? And you know, there's a lot of guidelines. There's really no set one guideline. All these academies, even the American Academy of Sports Medicine, the American Academy of Neurology, they come up with their own guidelines. They collect a bunch of people, neuropsychologists, neurosurgeons, neurologists. They all get together and make guidelines. They say, this is what we think the guidelines should say. So here's some. So there's three management issues, basically, you know. The acutely injured athlete to identify potential neurosurgical emergencies. So, you know, if it was a severe concussion, trauma, you know, whoever the doctor on site is, whoever is evaluating the patient, the medical professional, should keep in mind that, is there some kind of intracranial problem that this person needs to get to the hospital ASAP? Like, did they get hard enough, hit hard enough that there might be some kind of intracranial damage, some bleed or something that needs a professional like a neurosurgeon or somebody to address. Prevention of catastrophic outcomes related to acute brain swelling. Now, you don't have to have a bleed. If you got hit hard enough and a lot of neurons died and they start to swell, then that swelling alone could lead possibly to herniation. You know, like I mentioned, the brain trying to squeeze out, the pressure squeezing the brain out of places or pushing it where it's not really supposed to go. And then, you know, try to avoid cumulative damage. You get hit once, twice, 3 times, 4 times, the more you get concussions, it's not good for your brain. this is an old rule, you know. Quigley back in '45 said, you know, if you've had 3 concussions, just get out, you know. So, but there's, you know, there's difference. It's a little old rule basically, but this is the American College of Sports Medicine. You know, and there's 3 grades of concussions, the third one being the worst. You know, you can see there, this is their guidelines, what they say, and what they recommend as part of the management on the bottom, basically. I'll skip to, this is another one, I'll skip to the American Academy of Neurology one that I'm much more familiar with, and 3 grades. The difference, well, first of all, 3 is kind of separate from 1 and 2. 3 means that there was any loss of consciousness. I don't care if it was 2 seconds. There was a complete loss of consciousness. The patient lost consciousness. 1 and 2, no loss of consciousness, but confusion, loss of awareness, like kind of that awake, answering questions, but patient's not quite there, not following commands. And there's a time limit for 1 and 2, you know, less than 15 minutes and over 15 minutes. That means by 15 minutes for grade 1, the patient is back to normal, their old self. Completely back to normal. Like before they even got hit, like they never got hit. Number 2 is it's more than 15 minutes. Patient's still dazed, confused, has some symptoms. 3, loss of consciousness. So what do they recommend for grade 1? Athlete may return to play if asymptomatic at 15 minutes. This has changed a little bit. This is, you know, 1997. I'll add to what they say now. May return to play not just if they're back to normal, they say, oh, I'm back to normal, let me go back and play. You know, there's usually somebody hopefully on site, you know, doesn't have to be specifically a neurologist, somebody who's at least understands these guidelines or knows how to evaluate a patient to see that, you know, are they really in fact back to their old self before they go back and play and get a second concussion within a short window and then really have much more problems than they would have had if it just sat out. Athlete can return to play if asymptomatic for 1 week. That's if you have a grade 2. And then grade 3, obviously, you know, take them to the hospital. Observe, and patient passed out. It takes a lot to completely knock somebody out, brain related. I'm talking about heart, I'm not talking about other brain related. That means both hemispheres had to be knocked out by something to knock somebody out. So that's kind of big. It could have been some kind of a bleed, that, you know, that hemorrhage, that stroke, whatever it is, that injury, traumatic brain bleed caused somebody to pass out. So that's something that needs brain scan, a professional, maybe neurologist, somebody to see the patient. This is a little slide on concussion in sports, in group sport. What I'll do is I'll just skip over. I want to get to this concussion management, acute injury. This is kind of thing I would really like to touch more time on. I don't want to take too much time on the other things, but so any signs or symptoms of a concussion should not be allowed to return to play in the current game or practice. This is new, not like the grade 1 that I said. You know, 15 minutes, patients back to their old self, go back and play. No. If they really had a concussion, if they have any of those signs on the previous slides I talked to you guys about, they look like they're like that, I would not allow them to go back that day and play. Should not be left alone. This is even afterwards, not during the game, when they go home, you know, because they could be lucid and fine that day and then they could just deteriorate a few hours later. Should be medically evaluated. You know, make an appointment with whoever your doctor is. Doesn't have to be in the emergency department, but, you know, within a few days, if they're okay, you should still have somebody see them. And then, you know, return to play must follow a medically supervised stepwise process. Not just one evaluation, they're fine, and just go back to play. And I'll get in a little doubt. That's a good little quote there. When in doubt, sit them out. You know, so what? They didn't play the rest of the game. At least they didn't end up in some bad neurological issue. Sideline evaluation, this is just a few things. I know it's maybe not by being able to see in the back, but, you know, I'm not going to get into too much. Orientation, you get points for all of it, and then you get a total score at the end, and then there's ranges that, you know, say how bad somebody is, I guess, and you could just go with this with the patient. You know, concentration, you give them some numbers, tell them to repeat, recall, whatever. There's memory. It checks the different parts of the brain, basically. And then they came up with a sport concussion assessment tool. It's called the SCAT, basically. And what it is that I'll just quickly go. It consists of all these things: sideline assessment, Glasgow Coma Scale. You know, you could check the eye-opening, best verbal response, best motor response, and then you get a total score out of 15. Won't get into the specifics because we'll be here forever. But Mad Dog score, it's another thing. You know, like what venue are we at today? Simple questions. You know, that if you didn't have a concussion, anybody could obviously answer. But if you do, then obviously you might not be able to. So again, you ask, which half is it now, whatever, who scored last in this match, just give them scores and then you get a score. And this is the second part of that assessment tool, basically. Background, like you can talk to the patient a little about their history. Is this your first concussion? Number 2, what happened with your first concussion? How long did it take you to recover? What symptoms do you still have? Blah, blah, blah. Kind of go through that. This is another long kind of, how do you feel, basically, blurred vision, dizziness, any of this stuff, basically. You get different scores. None, mild, moderate, severe, you get a total score on the bottom. And this goes again into this assessment at the end. You get this total score. Neck examination, balance examination, coordination, delayed recall. You tell somebody, remember these 3 words. 10 minutes later, what are those 3 words I told you? Some of them might not remember any one of them. Some might remember 1 out of 3, whatever. They get scores for all of this, basically. Neck range of motion, if there was some neck issuance. They've added all this to make it more elaborate now. Before it used to be one or two sideline evaluations, but now they want to get the whole person as what's going on with that person. Scoring summary, you put all that stuff in here, and then you come up with a total, and then there's certain ranges that you can find the patient to be. So, stepwise, like I mentioned, this is what I meant by stepwise. No activity, complete rest. Once asymptomatic, you can go to step 2. Light aerobic exercise, walking stationary, no resistance training, nobody tackling you. Okay, just light exercise, whatever, fast walking, not, marathon or anything like that. Sports-specific exercises, you could get into like resistance training at, steps 3 and 4, non-contact training drills. Full contact training after medical clearance. So once you've gone to step 5, the doctor says, whoever it is you're seeing, neurologist, most times it is a neurologist, they go through all this stuff, and once they see that you're okay to get back, then you're okay to get back. Mind you that if you're okay to get back, you can also have a second concussion again. Nobody could prevent that. That's part of the sport or wherever it is that you're playing or doing. And if any symptoms persist, any one of those steps, you just drop back to the previous asymptomatic level and then slowly progress again. Good rule on the bottom. In every day, you just kind of advance. And then there's specific neuropsychologists, neuropsych testing. They could check for all this stuff, cognitive function, see how the patient is doing. Do we need brain imaging? If the patient passed out, loss of consciousness, grade 3 concussion, I would go to the hospital and get some kind of brain imaging. Mind you, in 80–90% of concussions, MRIs are completely normal because MRI will not show neuronal death or brain cell death. It won't show it. It's more of a clinical, what the doctor sees, these symptoms. The MRI brain is not going to say, like neurons died in this area. It doesn't show up. There are now more sensitive types of MRI stuff, MRI sequences that they do that might show a little bit here and there, but like I said, most times imaging in mild to moderate concussions is completely normal. And in conclusions, let me wrap this up. Repetitive concussions increase the chances of second impact syndrome. So make sure that there's proper stepwise return to play, like I talked about, proper clearance. No athlete should return to sport until all concussive symptoms have resolved, at rest and with exertion, not just at rest, because sometimes the activity could bring some of those symptoms out. Try to prevent catastrophic stuff, repeat concussion, maybe a bleed, maybe some kind of herniation, some kind of permanent brain damage. This is the whole goal of the stepwise fashion, to go through it and make sure that every step of the way they're followed correctly before they return to play. And all athletes suspected of having sustained concussions should undergo thorough evaluation, neurologic testing. If there's a need for imaging, absolutely get imaging, rule anything out. And if there's any other tests that need to be done, neuropsych and stuff, that could always be part of the workup and assessment. So I'll just skip over this. This is just, sorry, it's a quick case. 17-year-old male lost consciousness. LOC is loss of consciousness following a football tackle. He had retrograde amnesia to the day's event. He didn't remember anything that happened right until he got tackled and passed out. Confusion, initial weakness. This is his second concussion, not his first. Brought to the ER by the family for evaluation. Exam. He's alert. He's awake. He's oriented. He knows what year it is, the date, where he's at, who his family is, that's fine, follows commands, but he's slow. he's slow. You know, he's doing things, but he's slow. He's not himself. You know, usually he's a lot faster according to the family. Non-focal means his neurological exam done by a neurologist or someone doing, non-neurologist doing an exam is normal, basically. Non-focal means normal. They do a brain scan, the head CT is normal, which is the case, most cases it is normal. Final diagnosis, closed head injury with loss of consciousness or a grade 3 concussion, basically. You know, you plan to discharge the patient home, family's care. And what should you tell the family? You know, he has to be watched pretty closely. He had a grade 3 concussion. You have to tell them that no activity, complete rest, and then make sure you follow up with someone the next few days, physician, 1 or 2, 3 days, to see if, you know, nothing else is developing. If anything starts to go downhill, he needs to come back to the hospital for further evaluation. And that's it.